welcome everyone to our first Game Changer seminar of 2024, and great to see everyone, and also welcome to those people online. I'd like to acknowledge the traditional custodians on the land that we're on today and recognise their continuing connection with land, waters and community. We pay our deep respects to them and their cultures, and to elders past, present and emerging. So it's a great privilege to have the current Chief Executive Officer of the National Health and Medical Research Council, Professor Steve Wesselingh, here today at TRI. Welcome back to TRI, Steve. It's great to have you here. Steve took up the position as CEO of NHMRC in August 2023. Professor Wesselingh is an infectious diseases physician and researcher. He undertook his undergraduate and doctoral training at Flinders University, and we just heard how he was in the third year of that intake at a very new medical school when he spoke with our EMCR group in the last hour. His postdoctoral training was undertaken at Johns Hopkins in the US, and between 2007 and 2011, he was the Dean of the Faculty of Medicine, Nursing and Health Sciences at Monash University in Melbourne. Until July of last year, he was the inaugural Executive Director of the South Australian Health and Medical Research Institute, SAMRI. And I can also personally thank Steve because he bailed me out in my first year as the CEO of this organisation, as he'd been in post at that stage for more than a decade, and it was incredibly helpful to hear how he survived his first year or two. He's a member of he has been a member of NHMRC Council, chair of their research committee, and president of the Australian Academy of Health and Medical Sciences. We're really honoured to have you here today, Steve, and thanks for travelling from Canberra or Adelaide or both. It's great to have you back. Thank you.
Thanks very much, and thanks for the invitation to be here. And I've really enjoyed the morning so far. We had a great tour of the facilities and the amazing core facilities that you do have, and looked really terrific. And then the EMCRs sort of gave me a bit of a hard time asking all sorts of questions, and but they were terrific questions, and I really enjoyed that as well. So a great opportunity to talk to you today. So I would also like to acknowledge the traditional custodians of the land that we're on, and acknowledge elders past and present, and also acknowledge any Aboriginal or Torres Strait Islanders that are in the room today or online. So I guess this slide, I use this slide at the beginning of a lot of my talks because I actually do believe that it's a really important time in Australian health and medical research. And that's for a number of reasons. One is that I think it's clear that there are enormous health challenges, and I think our health ministers are facing these challenges, our population are facing these challenges, our hospital administrators are facing these challenges, and we can see them in the press every day. Increasing chronic disease, emerging threats of infectious diseases, and we've obviously just had a pandemic which we've all sort of forgotten about and assuming we won't get another one when we will. Things like obesity, cancer, dementia, huge problem that's entering our health system right now. Aboriginal and Torres Strait Islander health, ED, congestion, and then issues around rural and remote and primary care, which are really difficult. And then how do we run a sustainable health system? But the reason why I think it's important to highlight those is that I believe the answers to those questions lie in innovation and research and discovery. And that's what NHMRC funds and ARC and others fund, and you guys do. And it's really up to us, I think, to bring forward the innovations that can help deal with those significant health challenges. And every day, and tours like the one I had today, looking at imaging as an example, there's an enormous amount of discovery going on in genomics, in gene therapy, in new obesity drugs. AI, I'll talk about a little bit later, vaccine development, cancer treatments have changed dramatically, artificial organs, bioprinting, imaging, robotics, the whole lot. That the answers to our health challenges are in our innovation and discovery and our research and our movement of that research into new drugs, new treatments, into new policies, and to new public health and prevention. So the answers are there. We just need to work out how we link the whole thing together. And I guess in terms of that, I think there are a couple of opportunities that sort of sit with us, that is NHMRC, and with the people in the room. And that is the opportunity to look at how we fund through the MRFF and the NHMRC, and then the development of a national health and medical research strategy. So a coordinated strategy across the country around national health and medical research. And I'll talk about both of those things as I go along. So in terms of the medical research funding landscape, I'm going to talk mainly about the NHMRC and the MRFF, but we shouldn't forget that the Australian Research Council, the CSIRO, and the Department of Industry and Science and Resources are also playing in this game. And actually one of my goals in Canberra is to try and bring those 5 groups together more and have us talking together more. And already we now have a regular meeting between the NHMRC, the ARC and CSIRO. That's partly because the new head of the CSIRO was the head of WEHI, Doug Hilton, and is a good friend of mine, so it's good to catch up and have a drink. But we've pulled in the ARC as well as in terms of those meetings. But I'd like really to get those groups working more closely together than they have so far. This is a point that I made to the EMCRs, and that is, this is our endowment account. So this is the money that we have available to spend every year on health and medical research. So it's almost $1 billion. But you can see that over the period, it's been relatively flat, particularly over the last decade. And so that does constrain us in terms of what we can do. But it makes us try really hard to do the best we can with what we've got. We look at what we spend by setting priorities, and we have recently set our priorities for 2024 and 2025. And you can see this on our website, but you can see a number of particularly important things that I'm going to talk about today, particularly things like harmonising the MRFF and the MREA, excellence in peer review, equity in health research, issues around confidence in research and integrity, and issues around promoting prevention and public health. And you can see across the bottom there, our health priorities, and obviously Aboriginal and Torres Strait Islander health is an absolute priority. Emerging technologies has always been a priority for us, but over the next couple of years, we're going to concentrate particularly on artificial intelligence because of the impact we think it's going to have on health and medical research, on healthcare delivery, but also on peer review and the work that we do. And you can see the multiple groups that we need to work with in order to achieve our strategy. I mentioned the Medical Research Future Fund, and that fund is a future fund, so it has about $20 billion in the fund, and the annual disbursement has reached about $650 million a year. So it's added on to the almost billion that we give out. So the annual disbursement for health and medical research is about $1.7 billion a year. And in fact, if the fund makes more money, which it is at the moment, there's actually a little bit more money to be made available. And I think part of the strategy discussion should be about if there is more money, what would we do with it? The concept of the MRFF working more closely with the MREA or the NHMRC has been talked about for a little while over the last 24 months or so. And there was a lot of stakeholder consultation, and a discussion paper was written, and a consultation summary report was written. And really the outcomes of that were that most people felt that the two funds had unique benefits, and that those unique benefits should be preserved and promoted. One was a priority-driven fund, and the other one was a bottom-up, investigator-driven, excellence-driven fund. And so they were seen as delivering benefits across in different ways across the research ecosystem. But generally, the community felt that the fund should be managed by a single agency, that being the NHMRC. So what's happened next? So the Minister announced on the 2nd of May a few things. He announced the development of a National Health and Medical Research Strategy. So initially, we had talked about the harmonisation getting done and finished and then moving on to the strategy. But the Minister has now felt that actually we need to start developing the strategy while we continue on with the harmonisation. The consultation report was released on the alignment and reform recommendations. And in addition, at the same press conference, the Minister announced the one-stop shop for clinical trials that Ian Chubb has been championing for so long, which was another terrific announcement. So the government's still considering exactly how we join the MREA and the MRFF together, but while that's happening, they're quite happy, and we're very happy to continue to work on the alignment and the harmonisation. So what we've done is developed 8 working groups across the 2 agencies, about 100 staff combined, who are working on all sorts of things like early and mid-career research funding, like commercialisation, like procedures and policies, really trying to strengthen the synergies between the 2 funds, removing duplication, ideally getting all the grant calls and grant opportunities to look very similar so people can put in similar CVs and those sorts of things, and really ensure that, that we're really moving along the path to improving things like commercialisation together. In addition, what we've done, and it will appear on a subsequent slide, is we've looked at the governance, because one of the issues was that these funds were separately governed, and still will be. There'll still be AMRAB looking after the MRFF and the council looking after NHMRC, but all of the principal committees under those 2 will be joint committees advising both funds, which I think will be really important. So here's the diagram, and you can see research committee in the middle there. That's the most important of the principal committees, but you can see that the Indigenous Advisory Group will be advising both NHMRC and MRFF. In the past, we had 2 separate Indigenous advisory groups. Public Health and Health Systems Committee will be advising both. In the Industry, Philanthropy and Commercialisation Committee will be advising both. Consumer Advisor Group, again, we had 2 consumer advisory groups. Now we're bringing them into 1. And all of those groups are now open for nominations, by the way. So anyone who would like to be on one of those committees can nominate to NHMRC to go on to the committee. It's a ministerial process, so we get all the nominations, put together all the names, select the names, put them up to the minister. So it's quite a process, but we are keen to have good geographic representation, obviously gender equity, and all sorts of other representation on those committees, but keen for people to put their hands up for those committees. The other thing we have is the chief medical officers from every state coming and meeting with us and giving advice to NHMRC and the MRFF. And then they also sit on council. So that is a good way of getting the states involved in talking about health and medical research strategy. So what are the next steps? So as I mentioned, the minister announced that he wanted us to develop a national strategy for health and medical research, and that this strategy would cover the entire sector and include all levels of government, industry, philanthropy, academia and consumer. So basically everyone. And that's in the early phases of development, but a number of things have happened. We will be working together with the department on the development of that strategy. A chair will be appointed, and that will be announced shortly. And other things have already happened. We've started a health and medical research workforce audit. So we really wanted to understand, what does the workforce look like? Because we do get a lot of commentary, and I was talking about this earlier, about whether the biomedical workforce is growing or shrinking, whether the clinician researcher workforce is disappearing or is growing. We want to know what's the role of, where are nurses and allied health in our health and medical research workforce? those sorts of questions are really important, and the audit will be looking at that. We also want to know where's all the funding? I mean, I talked to you about $1.7 billion of funding, but there's a whole lot of other funding out there from philanthropy, from the states, from the Department of Industry, from CSIRO. And so we're doing a funding landscape review. We're doing a lot of focus groups with the community. We're developing a prioritisation framework and extensive public consultation right across the board. So I think this is a real opportunity for everyone in this room, to be involved in the development of our health and medical research strategy. And to be honest, I don't think we've ever had a national health and medical research strategy. We had the McKeon review, which was terrific, the Wills review, which led to an increase in funding for NHMRC, but they were not really strategies, they were recommendations to government. Development of a national strategy, I think, is a really exciting development that I think everyone needs to be part of. And here I've written a few things which I think are really important about how the strategy should help us impact on the health challenges of our time, in terms of workforce, in terms of partnerships, in terms of consumers. Importantly, and the Academy of Health and Medical Sciences talked quite a lot about this, it needs to ensure that our research is embedded in health. So healthcare is only going to improve if it's evidence-based and has research embedded in it. And we also, and this is one of the areas that, one of the reasons why we decided to have a principal committee on commercialisation, we're not very good at the end of the pipeline. On the OECD, we do really well in the early part of the pipeline and in clinical trials, but in terms of industry and commercialisation, we're not very good. And I really think that our strategy needs to make sure that we go all the way along that pipeline. And certainly some of the things I saw this morning and some of my conversations this morning would indicate that right here, you're doing that better than I can see elsewhere in the country. So that's really important. And obviously, this strategy needs to be developed through an equity lens, and there has to be integrity, and there has to be robust expert peer review. And I'll talk about those in a minute, or right now. So you can see here that there are a number of areas of peer review that we're interested in, all areas of peer review, but there are some particular areas that we're looking at right now. One is the Indigenous Research Excellence criteria. So how do we judge Indigenous research, and what are those criteria? I've been working with our Indigenous Advisory Committee for some time on the IREC implementation, and that's going to take place very shortly. How do we measure impact? And the impact part of the investigator grant is a really important process, and there'll be some changes in that over the next little while. And we've done a lot of work on impact assessment, and we've written a document on that, which is available on the web. I'm quite keen for us to test some things in our peer review processes. And so one of them is an iterative process. So traditionally, NHMRCs, you put in a grant, we review it, we give you a score, you get funded or you don't, and that's the end of it, and you come back again with a totally new or seemingly new grant. But I think there are some areas where it would be better for you to put in a grant. If you didn't get funded, you could take on some of the advice, improve the grant, and then bring it back to us. And maybe in the clinical trials and cohort studies, that might be possible. So I've asked our team to start looking at how we can develop some more iterative processes to improve the quality of peer review. One of the interesting things that we do is app-centric peer review. So when people put in a grant, we have an algorithm that looks at all of our peer reviewers and works out who are the best peer reviewers for that particular grant. And then every grant gets allocated 5 peer reviewers. And we are continuing to develop those algorithms, and we actually lead the world in that process. And we are really happy with our app-centric, application-centric grant process, but we would like to improve it. We'd like to see those 5 reviewers perhaps communicating a little bit in terms of sharing scores and comments and so on. So there's a whole lot of work happening in that area. We constantly look at the statistics around our peer review and our peer review analysis committee, and There's an NHMRC report on that committee's work, and it will look at all of the issues like noise around peer review, outliers, all sorts of activities that the PRAC committee has looked at, and continually feed back to the NHMRC in terms of improving peer review. AI is a really interesting area, and we made a determination that people could use AI to write their grants, but at their own risk. And if AI made stuff up, then obviously that wouldn't be helpful. And it does make stuff up from time to time. But we ask people not to use AI in terms of peer review, because obviously that would breach the confidentiality of the particular peer reviewer grant assessment process. But we do think that over time, AI and machine learning is going to have an even more important impact on the peer review process, on application-centric allocations and so on. So we are keen to continue to work in that area and learn in that area. And obviously AI is just going to have an enormous impact on health research and healthcare delivery generally. And the ethics and integrity around that are going to be really important. And for that reason, we had a workshop recently, brought in all the people around from the AI community to talk to us about their concerns and learnings in that area. And a report about that workshop will come out shortly. I said this morning that I felt that peer review training, well, I was asked a question about peer review training. I said how important it was. But the other part of that, I think, is the accreditation and acknowledgement of peer review by organisations. And so I suggested that TRI should have a prize for the person who does the most or the best peer review, or a series of prizes for peer review. So, because peer review is such an integral part of our system. And I also believe that if you do more peer review, you'll write better grants and have more chance of getting funded. We're also keen to have more consumer and community involvement in our peer review and build capacity and capability around that. The other area that I'm keen for NHMRC to build, and we're particularly doing this at an international level, is research on research. So there's now a number of organisations around the world who are asking questions about how we fund research. And a lot of those questions are the ones I just talked about. But we can gather that data together, work with our international partners, and really have our peer review based on evidence by growing our capability around research on research. Also important that, that we do continue to evaluate what we do, and we publish those evaluations. So as an example, the research impact position statement we published in 2022, and then in 2024 we published the impact track record assessment framework evaluation. And so though obviously at one point we said it's important to measure impact, and then we said, well, let's see how we're going at measuring impact in terms of impact track record. And there were a number of recommendations in that assessment or evaluation that we're taking on board. So there's lots of stuff on our website that people want to look at in terms of our ongoing measurement and looking at the issues that we're trying to address. Equity is incredibly important, and I constantly say to my staff, we need to look at this through an equity lens. And we look at equity in two ways. One is the impact on health generally. So we need to make sure that our impact on health is equitable, and obviously the biggest inequity in Australia is the gap between Aboriginal and Torres Strait Islander health and the rest of the country, and we need to be part of closing that gap, and we've said that very clearly. But we also need to make sure that we are equitable in terms of workforce, and so that we're not only closing the gap in terms of health, but that we're increasing capability and capacity in areas where there's inequity in terms of the workforce. And that includes gender, includes rural and remote, but also includes Aboriginal and Torres Strait Islander. And we've been really, really proud of our gender activities. And again, I would argue that we lead the world in terms of gender equity in health and medical research. And this year, women obtained more funding, about $7 million, more funding than men in terms of all of our grant schemes, compared to about 3 or 4 years ago, where men got about $70 million more than women. So there has been some major shifts in terms of gender equity across our schemes, and we're very proud of that, because we believe there has been a systematic bias in terms of women in our health and medical research schemes, and we are happy that we're starting to address that. We're also involved in things like the Statement on Sex, Gender, Variations of Sex Characteristics and Sexual Orientation in Health and Medical Research, and that was a joint draft, a joint statement that has now been released. In addition, we want to make sure that our trials look through an equity lens in terms of inclusivity for pregnant women and young children. And also, right now, we're in the middle of developing our consumer statement to make sure that consumers are involved in health and medical research. And obviously, at a regional and international level, we want to make sure that we look at things through an equity lens. In terms of Aboriginal and Torres Strait Islander health, we've been really happy that we aimed for 5% of our total expenditure to be on Aboriginal and Torres Strait Islander health and medical research, and we're actually up to 8%. So that has been a terrific outcome, and we've been very proud of that. But what we're unhappy with is that only 1.7% of our grants have a CIA who is Aboriginal or Torres Strait Islander, and we've set a target of 3.4%, and our goal is to get up to that, to increase that 1.7, double it up to 3.4%. One of our concerns is a sense that perhaps the community from time to time worries about the quality of our research and the integrity of our research. And so we're very keen to ensure the community sees that we see quality rather than quantity as much more important. And I do believe you get what you measure and what you pay for. So if we measure and expect people to have 200 or 300 publications, that's what we'll get. If we expect people to have some really great publications, but we don't really care how many, and so we only ask them to show us their 10 best, that's what we'll get. And that's what we've done. And I think that that is improving the quality of the research and the quality of the publications that people are producing. So I do think, and importantly, I mentioned international activities. So the DORA principles, or the Declaration on Research Assessment, fits into that perfectly, and that is an international announcement around the principles of research assessment. I also think the public has to have confidence in the integrity of our research, and we in the ARC have a committee called the Australian Research Integrity Committee that can look at the processes of integrity across the country, but can't actually investigate issues of integrity. We're keen to look at that more closely, and so we are going to do a public consultation, go around the country to talk to people about integrity as an issue in research. We think it's pretty good in Australia, but we do think it can be better, and we do think if we lose the public's confidence in the integrity of our research, we will lose the social license to do research. So it's a really, really important area to be treated really carefully. But we in the ARC are keen to do some more work on that and make sure that the public can have complete confidence in the integrity of the research that we're doing. The other thing that we do that a lot of people don't necessarily know about are clinical and public health guidelines. So we spend a lot of time working on both writing internally clinical and public health guidelines, or endorsing other people's guidelines. We have guidelines on guidelines. So we tell people how they should write guidelines, how to avoid conflicts of interest, how to get the best evidence, and things like the immunisation handbook, which is written by ATAGI, actually comes up to NHMRC for endorsement. We endorse things like water quality guidelines. And right now there's obviously a public debate about PFAS. And we are in the middle of looking at the evidence around PFAS, and then having a public consultation around PFAS and the levels that we need to set for our public water. So that's a really important part of the NHMRC, and I do think that it helps strengthen and builds the public confidence in health and medical research, and obviously in the NHMRC as well. And obviously, as I mentioned, our ethics guidelines, our oversight of all the human ethics committees and animal ethics committees around the country is really important as well. So in conclusion, I do think that there are a number of things that you could sort of set as guiding principles for what I believe is an internationally regarded high quality health and medical research funding system, and a funding system that ensures Australia can meet the health challenges of the next decade. And so I do think, and this question sort of came up a bit earlier today, about, you know, the transition from biomedical research all the way out to health policy and public health. But we need to be aware, what are the really big health challenges that we're facing now and in the future? And we need to make sure our health and medical research system is designed to meet those challenges. We have to, it has to be based on excellence, creativity, and innovation. But as I mentioned, we need to make sure it goes from the beginning of the pipeline all the way to the end of the pipeline. And actually, there's nothing wrong with creating jobs and wealth and companies on the basis of our health and medical research. Obviously, we need to also be sure that we're developing policy and public health and prevention as well. Our peer review processes have to be evidence-based and transparent. We need to look at things through an equity lens and make sure that we're not making equity worse, because often, you know, advances in health and medical research can actually decrease equity rather than increase equity. Sometimes, you know, some sort of cancer treatment could be more available at the Peter Mac than it might be in Northern Queensland. And that's a problem. We've got to make sure that those sorts of things don't happen. I think there will be an increasing role for consumers and community in health and medical research. And I think that will come out in the consumer statement. I think importantly, we need to make sure that we don't move away from investigator-driven research, but at the same time to have the capacity that the MRFF has to have top-down priority-driven research for areas that really need urgent investment, I think is really important. And as I've mentioned a couple of times, we need to make sure our research funding system is underpinned by research. And so right now, we're doing some work which is looking at the grants that won funding over the last 10 years or so, and looking at the impact of those grants. Did those grants really live up to what they said they were going to do? But more importantly, did they have impact in terms of patents, in terms of policy, in terms of public health, prevention, new treatments, and so on? And so that, I think that will be a really interesting view of our funding. Were we able to pick the best grants, the most innovative grants, and did they have the right outcome? And so we're always looking at ways of collecting evidence on what we do and to make sure that we can continue to improve it. And as I've mentioned a couple of times, we need to demand quality and integrity in the way the research is done. So on that, I might stop, and plenty of time for questions. Thank you.